So now I'm going to demonstrate piriformis and psoas, and the textbook has them listed in the area when it talks about femur. I sort of tend to think about it when I think of pelvis, so you can add this in when and where you think you need to add it in. If you've come back and done some femur adjustment, maybe you need to check piriformis, or maybe you've done a bunch of pelvis adjustment and adjusted to piriformis, then maybe you need to check femur. Okay, so your clinical decisions are going to make you think about what you need to test for. So for piriformis, what's the action of piriformis? Does it externally rotate the femur? Yeah, that would be piriformis, right? Externally rotating the femur. So I'm going to take her into flexion and take her foot slightly across midline, and then I'm going to tap on her malleolus because I want her to push medial. Patients don't know what medial is, but because I'm holding her foot here, they'll tend to push this way, and that's just because I got to hold her foot. So I'm going to say push into my hand and then let go. So she just more contracted the piriformis, and I look to see if the legs are reactive. If they're reactive, then she's got contraction going on, additional spasm going on in the piriformis. So to adjust it or to do a quick stretch to release that spasm, I'm going to go right into the piriformis muscle. It attaches to the anterolateral aspect of the sacrum and goes down and attaches to the trochanter. So I'm going to make my hand represent the piriformis at this point. And then you would go into the muscle, inferior lateral, inferior lateral, inferior lateral. So I didn't contact the sacrum and I didn't contact the trochanter. I went right into the muscle. When you're trying to find the muscle, if you start up at like just inferior to the crest at the fossa and start palpating down, if it's spasmed, you're gonna feel that ropiness or that spasm, and then you'll know right where it is when you need to set up inferior lateral, inferior lateral, inferior lateral, right into the piriformis. Yes?
So do you have to find the trigger point then, or the spasm, or just, okay?
You can try to if you want to, but pretty much if you go into 3 locations, you're gonna get it released, yeah. Okay, then I wanna recheck it. So I'm going to bend the knee, take it across midline, ask her to push back into my hand again and let go. And it's even, so I release that spasm. Now again, with your clinical processing, your thinking, let's say she had what activator calls an inferior sacrum or a base posterior. Then I'm gonna think, ooh, maybe she's got bilateral piriformis spasm. So then I might want to check this side also. So again, you just use your clinical judgment and decide whether you need to check both of them or just the one. Okay, now I'm going to check for psoas. So what's the job of the psoas muscle? Psoas, if the legs are flexed, it flexes. If legs are stationary, it flexes the trunk. If the trunk is stationary, it brings the knee towards the chest. So my test for that is I'm going to slightly bend her knees and I'm going to ask her to push her knees into the table. Okay, let go. And then I let her legs back down, and it's reactive in 1, and the PD leg gets shorter in 2. So I'm using the short long rule, and I'm going to go to the OPD side, saying she's got a right PD. I'm going to go to the OPD side and release the muscle on the left. Now when I did the test, I slightly bent her knees because it's easier for her to push her knees into the table with her knees slightly bent. If I left her legs extended, then it's going to be hard for her to push her knees in the table. So that's the reason I did it that way. So we're going to set up on the psoas. Are you okay to roll over? Okay, well, yeah. And then with activator protocol, PD leg got shorter, so I go to OPD side, and I would go right into the muscle and release it. but I'm going to show you how I release it in a second because I want to add this in. This is SOT. It's not activator, but it will better help you and it will help you save time. Because with activator, I did the leg check. I found out I needed to release the psoas on the left. Turn her over, do the release, stand her up, turn her around, put her back down. She pushes her knees in the table, read the leg lengths. Oh, it's not clear. Roll her over, set up on it, adjust it, stand her up, turn around, put her back down. So there's a lot of time going on with repositioning her. So when Activator first came out with this test, I'm gonna say, I don't know, 20 years ago, I thought, I don't know if that's really testing psoas. So I started comparing it to the SOT check for psoas. Well, sure enough, it correlated. So then I started just doing this in practice. So this is not activator, it's SOT, but it will just be time efficient for you in the clinic. So has anybody taken SOT? 1, 2 of you, 3 of you, okay. So I'm gonna do the check for psoas with SOT. Are you okay to stretch your arms above your head? Okay. Take a hold of the distal radius and ulna. You don't want to be distracting the wrist, so you're proximal to it, and have your feet on the same plane. If you have one foot in front of the other, then you're going to end up rotating. So your feet are on the same plane, and I'm going to distract, and I'm going to keep the distraction, point all of your fingers at me, and then I bring your hands together. I don't want her to do it, and I'm going to make this up. Bend your elbows, and look how your fingers are shorter on this side. So I show it to them. She's trying to, and the patients will do that. They don't like that it doesn't feel right or doesn't feel even. So they'll try to scoot that hand, and I'll tell them, you're cheating, quit doing that. And so I show them how their fingers are shorter, and that doesn't feel right to them. So I explain to them that the psoas muscle is a very large muscle. It attaches to all the lumbar vertebra and disc, and then goes down and attaches to the leg. They don't care where, but that's what I tell them. Then it also has some pieces that attach up into the diaphragm. So when I pull on her arms, because this is contracted and it's restricting or pulling down the diaphragm, it's gonna change the lack of motion in the rib cage. So when I stretch your arms above her head, that hand, that arm is shorter because of the restriction in the rib cage. So I need to go in and do a release on that psoas muscle. Have you had any abdominal surgeries? If they've just recently had some kind of surgery, I'm not going to go into the abdomen. If they're like 3 months out and they've been released from the surgeon, then I'll do it. But I want to make sure there's nothing there or anything that I need to avoid. So now will you point to your belly button? Okay, thanks. So if I went straight through from the umbilicus, where would I be anatomically? What level? Not dermatome, but what level? L3-ish, around L3, okay? So that just gives me a landmark. So I'm gonna go lateral from the umbilicus, push into the abdomen, place the activator, and my line of drive is inferior lateral, you okay? In the direction of the fibers. And I may do 1, 2. So about an inch apart. Now I'm gonna come back and recheck. Stretch your arms up again. And I'm gonna pull, point your fingers at me, and bend your elbows. And it's better, but it's not even. Can you stand it if I do it again? Okay. So I get them to buy into it because it's not comfortable. And so I ask them, can you handle it for me to do it again? I've never had anybody say no, but if they said no, I would respect that and then just check it on the next visit. So I'm going umbilicus, I went straight lateral, so now I'm gonna go a little more inferior and go deep into the muscle and adjust, and then recheck. And I'll stretch your arms up, and we'll see, did that. Bend your elbows, And look, it's shorter on the other side. So I need to do the other side. Can you handle that? So that might happen, or you may get them totally even. You may get them totally even after the first attempt. I will try 3 attempts. The first one at the level of the umbilicus, the second one inferior to the level of umbilicus. If I have to come back and do a third one, I'll go superior to the umbilicus. But 3's enough. If I don't get it after 3 attempts and they've seen it improve and I've just got a little bit that's not even, then I'll say I'm gonna make a note and we're gonna recheck that on the next visit. Because 3 attempts is enough. And the body may take care of it.
What's the one direction?
Inferior lateral, in the direction of the fibers, from the lumbar spine down to the leg. Yes, sir?
Can we do the SOT test for the practical, or do you want us to do
No.
that?
No, this is for your clinical usage, but since this is activator class, you'll have to do the activator check, which is push the knees into the table. So if you have to go to the other side, then you'll see that the other hand gets short, and then you would do the same thing on the other side. And you may have to go in 3 places. Most likely you're not gonna have to go in 3 places, but you might have to. Yes,
What setting is the activator on?
4, setting 4. Yes, okay.
Well, that's better than actually like somebody like holding down your psoas.
Yeah,
'Cause that hurts.
yeah. I mean, there's a manual, SOT does a manual release on the psoas, and it can be uncomfortable. Not that this is a breeze, but it's a little bit faster. So you got options there. Now, what about with pregnancy? I am not going near that pregnant uterus with an activator. Heaven forbid something happened to that child. It's not gonna be because of the activator, but I'm not gonna go there because I just don't wanna open it up for that. I will adjust pubic bone because that's inferior to the pregnant uterus. But I'm not gonna do psoas with an activator. I will use my fingertips to release a psoas, but I'm not gonna go near a pregnant uterus with an activator instrument. Okay, any other questions? Okay, thanks, Chris. You can turn it off.